for Derbyshire ICB. You probably see from the agendas that we've programmed a little bit differently. We've given a bit more time to the public board. We're trying to reduce the amount of stuff on the confidential board and give more time on the public board. There's some quite meaty items on today, and I'm really pleased actually. I know we've got Andy Morton, Clive, etc. here to see the papers on primary care, general practice, because strategically they're really important for us going forward, and we know that. Not just for the short term, but for the long term as well in terms of the prevention agenda. So that's great, and I'm really pleased to see that. I think it's worth noting actually, just for Stephen's backdrop actually reminded me of it. I was going to probably talk about something this morning. You know, we're held at this meeting's at a very busy time of the year. We're going into the winter period. We all know what that means traditionally. But also it's this time of the year, November, when we start looking at the last 6 months of the year. So that's how do we finish this year and run into next year, more importantly. But also we do start to look at next year. It tends to be that actually the last 6 months of this year, we're sort of dominated when we think about it by everything that's in front of us now, all those plates we've got spinning and all the stuff we've got to manage at the moment. But we've then got to somehow switch off and think about next year as the first year of the next 5 years and think about the longer term a bit. And I don't know about, I find it increasingly difficult to keep that balance between that shorter term and the longer term. And we talk about it a lot, and we're trying very, very hard as a system to get that bit right. But I was sort of thinking earlier about what's the sort of things that we should be really urging at this moment. And Stephen, looking at your backdrop, the one thing I put on my piece of paper was just to urge everybody to get their vaccinations. It's one of the biggest things we can actually do, and actually not just to get your own vaccination, but to encourage others to have it, especially the people in those hard to reach areas. You know, COVID's still out there, flu is still out there, MMR's still out there, measles, and really in terms of prevention in the public and the population, those are so important, and then so important to the smooth running of our organisations going forward, and they help reduce the load in this winter period. And so probably one of the things, that's what I think. And the other thing I was thinking about actually is really actually to appeal to the 300,000 people across the NHS to support each other at this time. It's really hard, and it's not just within our own organisations anymore. It's about between our organisations and with our partners. It's a tough time, and people are entering it already tired. And actually to take just a bit of time to reflect on all the good things we do. You know, we're all under pressure, but we're there when people are at the most vulnerable, and we do some great stuff. And, you know, it's time sometimes when we're all dealing with all these issues we've got, just put a bit of perspective and encourage everybody, just put some perspective into this. We do some good stuff, and we do some great things. And there was great things on the news as well as challenging things on the news this morning. You know, the way that they're starting to tackle some of those blood disorders like sickle cell and things like that. We're still doing great things. So please, and actually, I'll just to say thank you on behalf of the board to everybody, because I know how hard it is, and just, you know, we're doing good work. So please keep at it, and just make sure that that message gets out there that we do appreciate it, even though it does seem tough at times. So from me, and I suspect the rest of the board, thank you very much. So we've got a full agenda today, already spoken to it. We have got some apologies. I've got apologies from Tracy, from Andy Smith, Suzanne Pickering, Stephen Bateman, and Vicky. Thank you for coming along from DHU in place of Stephen. And also from Julian Corner. And I'll particularly mention Julian because everybody probably knows he's leaving us, and he's leaving us actually at the end of this month. And he's been with us since the start of the ICB, and I really want to put on record our thanks to him. Julian brought a way of thinking to us that was really complementary to the rest of the board. Actually, I don't know anybody that doesn't say Julian really comes out with some really interesting ways of thinking about things. And you actually see that in the business that he runs as well. If anybody takes the time out to go and see what the organisation that he runs does. And I think we'll miss him. It's a shame that his organisation's so successful that it's put so much pressure on him that he can't actually put the time into the NHS from our point of view. But, you know, it's brilliant for him. And so, you know, I just want to say thank you very much. He's not here to say thank you because he's on holiday. He's had a couple of failed holidays this year because of illness and all sorts of family matters. And so he's taken this opportunity to go now. But he will be leaving us at the end of this month. I would like to congratulate Jill Dentith. You're there somewhere, Jill. I know you are. We've, after an interview process, Jill has been appointed from her interim role into a permanent role as Julian's replacement. Although we'll see how things jobs are divided up going forward. But it's congratulations, Jill, and thank you very much for stepping in on the interim basis. But well done for the on the permanent basis. I'm also conscious that this time in the last board meeting we were saying goodbye to Zara Jones, and we're saying good hello this time to Michelle Arrowsmith, who's come in as, you know, I don't want to say Zara's replacement, Michelle, because you've got a completely different job title, and you've got a completely different role. You've come in as Director of Strategy and Delivery, and that's really important because actually that stresses we're very much in delivery mode as a system now, and you've got a really interesting background, and we're really looking forward to having you. And I can promise you we'll make you work hard for your dollar, if I'm being honest, if I know this ICB. But congratulations and welcome. Thank you very much. So without ado, I would say, just to confirm, we are quorate. And yes, there are any more declarations of interest than there are in the papers? Obviously, there are odd ones or two from Andy Mott, I would say, on the GP paper. Is that right, Avi? You've got your hand up.
Exactly the same thing, Chair, for the GP paper, that myself, Andy, and any of the GPs around the table. Yeah. Yeah,
that's okay. That's great. Thank you. And without ado, can we move on to the minutes of the last meeting? I'm not going to go through it page by page, but just ask, does everybody agree that's a proper record and of what we discussed and the spirit of what we discussed, actually? I'll take no hands as agreement. Great, thank you very much. They're approved. There's a lot of papers in this board pack this month, I have to say. I know some of them are for information, but go straight down to the action log. The first action log is on the integrated assurance report. I'm not going to say any more other than that. I have spoken to Michelle about this. It will be towards January when we start to see some others, but you'll probably see in the integrated performance report, there's constant stuff going on. I think the main thing we talked about, Michelle and I, were, yeah, how do we make sure we rationalise it and make sure that it covers that short term and the long term, and do it in a way that isn't thousands of pages long and causes thousands of hours of work in between pulling it together. So I think we're going to do that. But can I just congratulate certain things? I'm seeing much more information in there of us as a system, and there's much more primary care information in there, for instance, than there used to be. There used to be none, actually. There is that now, and we're starting to see, I see things in there that say this is a system now, and it runs from, you know, prevention right through to end of life, and it's all covered in there. And congratulations, Linda, on the workforce stuff. You seem to be getting a handle on the numbers much better than we had before. And so I just wanted to say, so we are moving on that, but it's an ongoing process, but I think you'll see some big changes. The other open item is with you, Keith, and it was stuff around the Staffordshire residents. You and I had a discussion the other day anyway, but I think you've got more or less covered for the next plan. Do you want to say anything else?
And thanks, Chair. Only that we've circulated a briefing note around all parts of the system after the last Finance and the State Subcommittee to socialise the problem that I articulated at the last board meeting, and it continues to be a regular theme with my conversations with the regional and national colleagues. So we're going to have to keep on in that space, to be honest, Chair, because it's not going to be an easy permanent solution, but it's out there. And also in capital, being really appreciative of conversations that I know Jim has had, who's on this call today, in his sphere of industry, to push the same point home. So it is beginning to get some resonance, but it's critical for our future that we do get a permanent solution to that national model of allocating resources. But it's out there, and it's we're not always popular, but we're doing the right thing for the Derbyshire system by having those conversations. I'll leave it there. Thank you.
Yeah, thank you. And I accept that. And we saw the briefing paper. I hope everybody saw the briefing paper, and it explains the problem. I'm not going to go into it anymore, but it's the difference between 3.3 billion and 2.3 billion, effectively, I think. Okay, so I'll move on from. Is everybody happy with the rest of the actions? That they complete? Great, I'll take that as a yes. Okay, move straight on. There's my chair's report in there. Thank you for helping me pull it together, Sean. I really appreciate it. I'm really not going to add too much more to what's in there. I sort of covered it in my welcome, other things that I'd like to say. The only thing I really want to add to that is that myself and Chris are going round and meeting all the local authorities, all the district councils, all the MPs on a routine basis. I think we've got 2 more MPs on Friday, Chris. We are trying to do some of this work and really engage with our partners. We had a really, really good visit, I felt, yesterday to North East Derbyshire District Council. A really good discussion and a really mature discussion about the wider determinants of health and our different roles in that, and where the demarcation lines were, what we could do for each other, where we didn't need to step on each other's toes, where we really need to support each other. It was a really, really honest discussion, I thought, but really held in a really constructive way. And that's what I'm generally finding. We got exactly the same when we went to Derbyshire Dales, and we're getting great discussions, I think, in the integrated into the ICP and the health and wellbeing boards. There's a maturing position on rationalising and understanding the golden thread of what we all do, what we don't do, where we support each other, etc. Would you say that as well, Chris, or would you like to add anything? That's my gut feel at this moment.
Completely concur, Chair, and we'll pick up in my report. Thank you.
Yeah. But on everything else, I just want to bring out the fact that, so everybody understands, that the board has started a programme around inclusion. We're holding it's a development programme. It runs over quite a few days. It's got 7 days in it, and it's very much geared about our understanding of what inclusion means in the future world, and how we actually don't just say inclusion, but understand how we make it part of our psyche and build it into the wider system. I know it'll translate out wider as we go on, but it was right for us as a board to get that training first and to get that development first. So I just want to make sure that everybody understands that we are really pushing ahead with this, and it will feature more strongly and stronger and stronger. If Penny Blackwell was here today, I would always talk about inclusion. She doesn't like to talk about equality of access. She thinks it's got the wrong things. I had a discussion with her about it 2 days ago, so she would always go for inclusion. So I'm always only ever going to from now on talk about inclusion. So everybody understands that. It covers equality of access, but she pointed out some really interesting things, and I'll get her to develop that for us later, actually. So that's my chair's report. Has anybody got any questions? No? Right, let's move straight on to Chris. The Chief
Thank you,
Exec's
Chair.
report.
Yep, thank you, Chair, and thank you, colleagues. I will pick out some really pertinent pieces from my report just to highlight, if that's okay, but won't go into the detail because I know colleagues will have read it in advance. I think there's something to bring up front around the messages you were saying there, Chair, around we're heading into winter, we're heading into an important year ahead in 24-25, never mind closing 23-24 in the best way. And we have a huge job collectively in the NHS family on focusing on operational delivery. And as we know, we will be, ensuring safety and quality of our urgent emergency care services, whilst also maintaining a focus on our planned care and our cancer care. That all said, what you've just been describing, Chair, about at the same time having a focus on the strategic direction, the next 5 years is what we're also doing, and it's about the balance of both of those things. So the purpose of those really important conversations with our partners is about 5 years. It's maintaining our focus and our influence across a broad stream of networks in terms of the wider determinants of health, which obviously most don't sit in the actual gift of the health service itself. So there's real purpose in what you've set out and strategic intent that we are setting out and going forward with. The point I want to bring out to board's attention, not that the board isn't aware of this, but it is really pertinent. We are starting our consultation formally with our team this Friday. Tomorrow I will kick off that consultation tomorrow morning, and we will continue to support our staff through for what for many will be a challenging time. And there is no good time to do this sort of work. It is necessary, but this is the best time in my view. And certainly I was walking the floor yesterday morning talking to my colleagues, and the view was, look, let's move forward with this. Let's have the detail. Let's work through it together, and let's work through it thoughtfully. So I know board will be sensitive to that. What I want to signal in that intent is the 3 roles of the ICB, and they are really important. So we have got a really important role in our statutory duties, making sure we've got the services out there that our population need and that they are good quality and service, and standard and safety. That is our statutory role. With that is coming an increasing oversight role that we're leaning into NHS England around and growing our expertise in. But equally, we've got an important role in supporting the NHS family become more integrated and effective in the way it delivers health and care. And part of that restructure in our mind is having a mind's eye to that around how the ICB has a facilitatory role, a supportive role, whilst our provider collaboratives and places become much more self-sustaining. But recognise that's a journey. It's not a light switch on and off. It's a journey, and we need to fine-tune our approach to that. And during the consultation period, I'll be having important conversations with provider leaders, place leaders, GP leaders, and so on, just to think about the role we play in that. And then what you signalled, Richard, around partnership, working with others on the wider determinants of health. The ICB, the NHS family, becoming a more influential and good partner in that broader regard, and that's why there is real purpose in the work that we're doing, real commitment in the work we're doing externally with others. So I hope that's helpful context. Just pulling out a couple more salient pieces. Of course, we've got a new Secretary of State, and I will update the board accordingly once we know more about the views of the new Secretary of State and the direction that comes from government in regard of health and care. And of course, it'd be remiss if I didn't pick out and give my sincere thanks to both colleagues working within the health service and colleagues outside of the health service that supported our collective effort to recover from, well, work through and recover from Storm Babette. We've had further storms since, and you know, even ourselves in terms of the administrative base, we have you know, Cardinal Square, you know, has been disrupted by floods, and obviously we don't provide direct care from here. So I know our colleagues out there providing direct care, you know, felt a significant challenge. But huge thanks, local authority, Environment Agency, and others that supported our recovery from that. Chair, the rest of the report picks out some important matters. You're seeing in the report elements like patient choice being described. You're seeing elements around information and data, and also you're seeing local news around awards, because during these times of challenge, we continue to make progress, and that's where we are in Derbyshire. So with that, I'll hand back to you, Chair, and obviously take any questions, and I'll be ably supported by my executive if there is anything out of my sphere of expertise. Thank you.
Thank you. And Jill, you've got your hand up.
Thanks, Chair. Apologies, my machine seems to keep drifting in and out of Wi-Fi signal, so if it all goes quiet, that's what's happening. Thanks, Chris, for the report, which was really helpful. I guess picking up on the staffing issues, I know many of the staff have been through this process, not infrequently, but nevertheless, it is a traumatic time for them, and I know colleagues will be working hard to support them. And I guess it's also thinking about the whole system, isn't it, and where perhaps there's suitable alternative employment within the bigger system arrangements where that can be supported. But yes, I know colleagues will be looking hard at this and making sure that people are safe, and that they feel that they've got that support, because the staff do work really hard and we can't do any of this without them. So it is really important, and thank you for that. Congratulations to everybody with the awards. I mean, that's fantastic news. Again, when people are working under such pressure, it's a tremendous acknowledgement of the hard work that's going on in the system. So I think that's really positive. And I just wanted to ask, you know, on the travel to treat arrangements, it's maybe too early to say whether that's having an impact, but that people can opt to travel to different locations for treatment. Presumably that's out and in. And I wondered if we got any feel for how that was impacting on our efficiency arrangements, and whether it was diverting staff away from our Derbyshire agenda to that sort of wider picture. But maybe it's a bit too early to kind of delve into that one, but happy to have any update if you've got anything. Thank you.
Thanks, Jill, and through you, Chair, I'll just say a couple of words on that, if that's okay. So I think it's fair to say, Jill, it will be too early from this new initiative to take a sense, but I think with that steer I gave around the importance of operational delivery, when we do our escalation reports, when Quality and Performance Committee reviews, that'll be something that you know, we'll be asking committee to look at, you know, seriously. I just want to point out though that choice it's not a new concept, and it's something we've been offering for some time. I think it's fair to say we've had different leanings with regards to choice over the years. There's been different emphases on it, but it's something that's been there for a long time, and historically we've always worked with other partners, both on the independent sector but within the NHS, to transfer care, and certainly something you'll hear a lot of around mutual aid is something that we've been doing, particularly through the pandemic and more latterly, around. It's an element of choice. So I wouldn't want to for us to think that the transfer of care between agencies is a new phenomenon, because, as you know, it's not. But
I guess
it's just because
it's been a national advertising campaign, so I wondered if that had an impact. Okay, thank you.
Let's bring it back. Thank you, Jim.
Okay, thanks.
Deji, I think you've got your hand up as well.
Thanks, Chair. I was just wondering if either Chris or the appropriate exec can just give a high-level summary from the virtual wards summit, because that's something that QMP are still particularly interested in.
I think it's a really great question, and I'm probably going to defer to expert colleagues. I've got Stephen and Chris Weiner who have been supporting the summit. Colleagues, do you want to come in and give some direct feedback? Thank you.
So shall I step into the space then, Chris?
Yeah, okay, Chris, all yours.
Okay, thank you. So yes, we had the virtual wards summit. I can't remember the exact date off the top of my head. It was in September time. We had broad engagement from right across the system. Acute Trust, Community Trust, Primary Care were present as well in terms of actually looking at the virtual wards process. I think actually what we had was a lot of enthusiasm to move forward and progress the development of virtual wards within that shared space and within that shared clinical environment. And I think that's really good news for us as a system, in the sense that we have a broad base of clinical support for the development and future development of virtual wards. We know that we're on a long-term journey of development for the virtual ward space. So it's been pushed hard this winter. I recognise that it's a national priority, but actually we are transforming the way we deliver healthcare, and this is a major transformation programme in terms of the development of the NHS. So I think what we're seeing today is the beginning of a journey which will take us through the next few years, and I see that commitment to the development from the national team as well in terms of the virtual ward space. In terms of what impact has that engagement development session had, we are, and I don't have the exact numbers at my fingertips today, Chris, but we are seeing an increase in the number of virtual ward bed spaces available, and we are seeing an increase in the bed utilisation of those virtual ward bed spaces. So beginning of this year, financial year, we were running around about 20%, maybe 25% bed utilisation. And we're now running fairly consistently above 50% bed utilisation. So we are seeing that change in clinical practice, and that engagement has helped drive that change in clinical practice. There is still a long way to go. We would like to see further bed use of those beds, particularly this winter, taking some of the strain, some of the pressure off the front door of acute trusts by being able to manage some of those people who could be managed in a virtual ward space in a home environment using the technology and the processes we've got in place. So I hope that helps as an update on the day. Key messages, really useful, really good day with good engagement from clinicians across the system, some improvement now, and a commitment to continuing to develop virtual wards going forward.
Thank you.
Thanks a lot for that, Chris. Yeah, Chris and Chris. I mean, for me, I'm glad to see that steady progress, which probably means it's an embedded change, which rather than quick, sharp things. But we all know that keeping people in hospital when they shouldn't be there is probably bad for them. So actually, this is a quality thing as well. And so well done. Thank you very much. Any more questions for Chris Clayton? I know, Stephen, you popped your hand up and popped it down again, but obviously sort of happened. Right, okay, let's move on. Helen, we've got the risk register and the BAF next on the agenda, if that's okay, and I think you're going to introduce these.
Thank you. Good morning, everybody, and thank you, Chair. Yes, so there are two reports this morning related to the risks facing the ICB. The first one is the monthly ICB risk register that the board sees each time, and those papers start at page 40, and then I'll turn to the board assurance framework for quarter 2 as the second report. So obviously lots of papers here. I think Chair, the papers probably contribute to 20-25% of the total pack, but important that the board sees the full range of detail and changes that have taken place over this last month, and indeed of course the last quarter for the BAF. But firstly, turning to the risk register. So this details all the risks facing the ICB that of course the committees regularly talk about as part of the work of the committees. We can see that during the month of October, early November, there's been some changes. So during October, there are 2 new risks that are being proposed. One, firstly, one relating to some national policy related to Agenda for Change pay awards for staff, and that's some staff who are delivering NHS services but aren't employed by the NHS in quite the same way, are potentially not able to receive that pay award as a result of the national policy. And the Finance, Estates and Digital Committee felt that that was a risk in terms of funding, how we locally fund those pay awards, but also the morale of those staff, recognising the important role that, of course, those staff groups play in delivering care and services in this system. So that's the first new risk that's being proposed on the ICB risk register. The second new risk is then related to performance, and I think we'll see this as a theme as we start to look at the integrated assurance report and some of the real challenges, of course, that we're facing and were alluded to in the Chair and Chief Exec's update there. So this new risk is related very specifically to performance against the cancer standards, including the 28-day faster diagnosis standard, the 62-day wait, and the 104 days due to an increase that we're seeing from the Staffordshire system into UHDB. So of course, we recognise that UHDB sits across Derbyshire and, of course, into Staffordshire, with the site there at Queen's in Burton as well, of course, the main site here in Derby. But of course, we do see referrals from our Staffordshire neighbours into UHD, and that is causing some significant capacity challenges. So we wanted to recognise that as a risk that we need to very closely monitor and review. In terms of then finally on this report, just to pull out, the third thing to highlight is the closed risk number 2, and this is a risk that relates to the changes to the interpretation of the Mental Health Act and the deprivation of liberty safeguards, and in discussions with the system quality group, it's recommended that that risk is now closed, and the rationale really for that is around the work that's being done with Midlands and Lancs Commissioning Support Unit to continue to process the applications and the confidence around the work that's now happening around that. So I'll pause there, Chair, on the ICB risk register. Happy to take any questions or anything other colleagues or chairs of committees may wish to add before we then move into the board assurance framework for the second item.
Yeah, well, I've got Jill's hand up already, Helen, so that, and I'd obviously, Mark, I'd just like your comment on the closure of risk 2 from the Derbyshire healthcare point of view. I can remember all the discussions about the Mental Health Act going forward in the past, so just make sure, quite like your comment before we actually agree to that, if that's okay. So Jill, then Andrew, and then Mark. Is that okay?
Thank you, Chair. Thank you, Helen. Just in terms of risk 22, as Helen said, we had a conversation at Finance, Estates and Digital Committee,
Yeah.
And that was the original wording that was proposed. When we had the conversation, the discussion turned to not only the sort of resource element of it, but also to the staff morale impact of it, and we're actually going through a process of rewording that risk slightly to make sure that it covers both those points. So if we can ask for this one to be sort of held in abeyance until we've had that conversation and then add it formally to the risk register, that would be really helpful. Thank you.
So yeah, the fact that it's going to be on the risk register but might have slightly different wording, I think we can agree that at this moment in time, possibly.
Thank you.
Andrew Moore.
Hi, thanks. Good morning, everyone.
Morning.
So same issue, and actually I welcome the rewording. So this risk obviously materially affects general practice as well. When you're looking at national pay awards and the income, and obviously that quantum of that impact is not managed in the same way because it falls on individual partnerships depending on the model of delivery of that particular organisation. But can we build general practice into that risk, please, because that's a significant part of it? Thanks.
It's a fair point, Andy, and I agree. And I will say well done to Keith Griffiths. He's been raising this outside of all of this, and I think it's exactly the right thing to do. Can't promise what result we'll get out of all of this, but I do know that Keith has really raised this at higher levels. So well done to Keith. I just want to acknowledge that. Mark, anything on closure of risk 2? Are you happy with that?
Yeah, I don't particularly have a comment because I think it's probably more related to, or less related to Derbyshire Healthcare more generally, I think, unless Helen corrects me otherwise. But it's more to do with just the interpretation, I think, of those particular things. And if the Midlands Commission Support Unit are now sort of taking the hold of that and less challenge, and that seems perfectly sensible. But Helen, I don't think this specifically relates to Derbyshire Healthcare, does it?
It doesn't, Mark. No, you're correct. It's the form as you described.
Yeah.
I'm sure you've got Mental Health Act on your risk register anyway, Mark, I would have thought.
Yeah, this is the Mental Capacity
somewhere in your
Act,
organisation.
Richard, it's the Mental Capacity Act, actually, rather than
Yeah,
the
Mental
Health
Capacity
Act.
Yeah. Sorry, Mental Capacity Act. I beg your pardon here. Deji.
Thanks, Chair. My question is in relation to risk 23, which is the new risk, which talks about flows in the cancer pathway from outside the area. That's specific about cancer, but I thought this affected more parts of the elective pathway, or is that covered elsewhere?
Yes, I believe so, Deji, it is. So in terms of meeting the performance standards, there is a risk more generally on that. But I believe that this was very specific to do with the increased referrals that we're specifically seeing from our Staffordshire neighbours, and the committee wanted that identified as a particular risk because I think there are particular focus pieces of work that are underway with that referral pathway with Staffordshire colleagues.
Thank you.
Paul.
Thank you, Chair. I was just supporting the risk being taken off with regards to the Mental Health Capacity Act. And just to note, it wasn't mentioned in the King's speech to Parliament. So there could be further delay in the development of that as well, which we'll need to keep a watchful eye on.
Right. And presumably, Stephen, you're happy with risk 23 as well. It's probably just worth asking that. Stephen Posey, if you're there.
Sorry, yes, I was doing a thumbs up, but yes, yeah. Thanks,
I can't see you. Your camera wasn't on, I don't think. That's great. That's fantastic. Okay, so I haven't got any more, but so just for we are approving the closure of risk 2, and we're accepting risk the 2 new risks, but accepting there will be some rewording of the 22. Is that fair? Great.
Thank you, Chair. That's really helpful.
And just to stress everybody that one of the purpose of the risk register, we praise the ICB board of the risk register. It's actually as well for you to benchmark all everything we're doing the meeting against. Are we tackling the actions that reduce the risk? I mean, that's the purpose of all of this. So, and that's why I've brought it very much to the front of the meeting. So please, when you look for assurance of things going forward, really, are we got big gaps in what we're doing that you really want to know more about, maybe in future meetings? And so please bear that in mind all the time. And it is a very live document, this now. If everybody looks at it, I had a quick look at the one from the beginning of the year, and it's moved massively, Helen, hasn't it? From where we were.
It has, Richard. And I think as we move into the board assurance framework for the next item, colleagues again will see the plethora of work now that's been underway during Q1 and in Q2 2. So if it's okay with yourself, Chair, shall I go into that one? Yeah, lovely, thank you. So colleagues, this set of papers does start around, I think, around about page 50, 54, 55 of your packs. So this is the clearly Q2 board assurance framework. So this covers the work that the committees we do across the organisation, and where we bring in system colleagues also across the last quarter, really reflecting the work that we do for the 10 strategic risks that we identified earlier in the year. This also picks up further work and feedback that we had through our internal audit colleagues. So we have the committee review report as well. So that's also been considered as part of the work that we've done in Q2. So you will see that there's been quite a lot of changes as a consequence of that to strengthen the work that we're doing. As you say, Richard, the importance of the controls, the gaps, are they working? If not, why not? What more do we need to do? Are we seeing changes in the risk score? Are we seeing some movement there, or are we just keeping the lid on things? And what more might we need to do? But I think the report does show there's greater maturity and ownership now in the committees and the discussions that we're seeing. So just with that in mind, and I will just pull out a couple of changes for the board, if I may. So you'll see that related to strategic risks 1 and 2, there are some changes to those risk scores. So strategic risk 1 is related to a risk that there's an increase in the need for healthcare intervention is not met in the most appropriate and timely way. Risk 2 is that there's a risk that the short-term operational needs hinder the pace and scale required to improve health outcomes and life expectancy. So the Quality and Performance Committee Task and Finish Working Group meets on a monthly basis to review the strategic risks that sit within that committee, and following that last meeting, discussions were held. And as a result, it's felt that both of those risks could be reduced as a result of the maturity now in the system and the further work that's happening across the whole system to support both of those risks. So the recommendation in the report is that they are reduced from a very high score of 20 to a score of 16. It's still very high, but that we are seeing some movement and some impact of those controls and mitigations. The second area to pull out then really is related to risks that sit within the Population Health and Strategic Commissioning Committee. And this is related to a thorough review from related to strategic risks 7 and 9, and some focus work that was undertaken during Q2, particularly around several system gaps in controls and assurances, and just understanding whether they are actually relevant to the risks and making an impact, and if not, let's review those, take them off, and make sure that we are adding in controls that do make a difference, and we are identifying the gaps and then the controls that make a difference. So as part of that, some refreshed wording was recommended that you'll see in blue related to those gaps and controls, and also a review of the actual description of risk 9, which I think at the last board meeting we had some discussion on in terms of the wording. So after consideration, it's felt that actually a new risk description would better fit the essence of what we're trying to say here for risk 9, that there is a risk that the gap in health and care widens due to a range of factors, including resources used to meet immediate priorities, which could limit the ability of the system to achieve long-term strategic objectives, obviously including, of course, reducing health inequalities and improved outcomes. So we're asking the board to note those changes and to support those recommendations. And then the final area just to pull out on this paper, if I may, Chair, is a transfer of strategic risk number 8. So previously risk 8 was separated into 2 parts, a part A and a part B, detailed here on page 57, where the first part was around establishing intelligence and analytical solutions to support effective decision making, and then part B was around the delivery of digital transformation. So again, during the more focused review during Q2, the original risk, which was the responsibility of the Finance and Estates and Digital Committee, it's been recommended that we split into two separate risks, and recognising that actually they would sit better in different committees because that's where the ownership would better fit. So we're recommending that the risk around not being able to establish intelligence and analytical solutions to support effective decision making sits now within the responsibility of the Population Health and Strategic Commissioning Committee. And then the risk that the system does not identify, prioritise, adequately resource digital transformation in order to improve outcomes would be better sit within the Finance, Estates and Digital Committee. So in summary, there are the 3 or 4 main changes. Obviously, you'll see the full report, and apologies, there's an awful lot of detail and the font is very tiny in the way that the PDF works. So I do apologise for that, but hopefully you'll see the plethora of work that's happened during Q2 and picking up a lot of discussions and maturing conversations that we've seen through the committees in the last quarter. I'll pause there, Chair, but happy to take any comments or questions, or indeed execs or chairs of the committees may wish to come in. Thank you.
Thank you very much, Helen. I've no hands up. Has anybody? Sue.
I would just like to echo what Helen said about how much this has developed over the last 6 months particularly, and how it does feel now that we've got targeted action to address the gaps that we've got in place. I just wondered if committees could have a particular focus in the next quarter on looking at how assured they are against some of the threats, particularly where the actions are being completed, and whether actually that means they can move to better than partial assurance. And if not, are there other things that need to be done? Because I noticed there's a couple in quality where the threats seem to be fully actioned, but they're still looking at partly assured. And I think it might just be worth revisiting those and just saying, why are we still only partially assured? Can we take more assurance, or is there actually some more work that needs to be done in these areas? But I think things have moved on tremendously, and I really think the individual elements underpin the work of the individual committees, as well as coming back to board to give us that assurance and structure our focus at these meetings.
Yeah, I would echo that. I think it's been great progress. I think it's worth maybe just reminding everyone, we have got a job to do, which is actually saying we're going to do things differently in the future. So we are changing. So to have no risk at this moment is impossible. Because you can't change things without some risk. But the risk of not doing something is often very much higher. And it's about what these documents are as much about is about how we managing the risk of the change sometimes correctly, just as much as anything else. And it's worth looking at them in that, as a dynamic organisation and as a dynamic system, rather than a static system all the time. We want to move forward. We understand that means change. We understand that potentially can bring risk, but how we manage it in the right way? Do we have a grip of it? Now, I feel, and I think what you're saying, Sue, is we have more of a grip of that now than we probably had, or it seems it, and it's providing more focus. So I want to say thank you to everybody that's doing it. Is anybody else got any more comments? Does everybody agree with that, or is everybody? Do you think that's probably a rose-tinted look at what we're doing? I don't think so. I think it's really very much about what we talk about continuously now, Helen, I believe. Is that right?
It is, Richard. So yeah, echo the comments, and clearly we do want to see that that change really as we go into quarter 3, and that assurance around each of the strategic risks, and the committees to focus part of their conversations around that aspect, whether partial assurance is indeed where we really are, or whether we're likely to see any changes to those in quarter 3.
Right. Okay. Without further ado, then I'll approve and note on behalf of the board, if that's okay.
Thank you.
and thank you very much for the work put in. So, and we'll move on. Okay, the next 2 items on the agenda are very much around primary care and GP general practice. I know last time we had Avi talking about clinical and professional, and I think it's really good as a board that we're starting to really focus on some of these areas and how they feed into that bigger operational picture. So Andy, I noticed it was Andy, I think you're going to bring the next one in. I noticed it was one of your practices that got an award last month for being warm. I think, yeah, that was what was in Chris's report. A practice up in the High Peaks. So there you are, you don't know about it, eh? But you said that you were warm. That practice was warm, which I thought was a really lovely way of describing it. But great introduction. So I'm really pleased to have your papers today, because we know how important primary care general practice is to us going forward. So I'm going to hand straight over to you and Craig, I think, on the first paper. Is that correct?
So I'm going to introduce, if that's okay. Thank you, Richard. So obviously I'm slightly changing my role now from being the ICB partner member for primary care into my my main non-clinical role as the medical director for the GP provider board. I've got a couple of colleagues who have joined me, so who will reintroduce themselves. That they have attended meetings previously. So Duncan Gooch and Ian Potter, but we're each going to say a few words. We're not going to spend hours talking to this, because obviously this follows on from the May development session that we facilitated up in Arkwright, if for those of you who remember that session. And this starts on page 98 of the pack if you're trying to find your way through the large number of papers. So one of the prime kind of outcomes from the development session in May was to kind of develop the emerging model that we presented into something a bit more tangible, into next steps. And we were invited to come back in the autumn, and this is where we're up to. And this is one of the real key functions of the Derby and Derbyshire General Practice Provider Board that obviously the ICB supports, and we have obviously an agreement about what our key functions are, and this is one of the key of those. So we're pleased to bring this back. And to try and describe a potential way forward and a future model that kind of distills the real key points and the real key benefits of general practice, but within the constraints, the environment in which we work, so particularly around workforce, which you will all be familiar with. So it's here for discussion, hopefully your endorsement for where we're up to, and then we need to consider the next steps as we've proposed them in the paper, as well as how the governance arrangements and how we potentially move into implementation of this. There's been a lot of work in the engagement around this, so we've been to lots of places and lots of meetings over a long period of time. So it's been to the Integrated Place Executive, it's been to the Provider Collaborative Leadership Board, all the general practice facing architecture in the system. It's been to PHSCC. We've also been to DCHS board development session. It's excellent timing. It's like your cat wandering across the screen. Apologies.
Oh, yeah, I'm sorry.
And Duncan and I were at Chesterfield Royal Hospital's private board meeting yesterday, indeed talking to this. And I know Duncan's also presented this to DHU. So this has evolved with input for a wide range of partners. So I'm going to hand over to Duncan, who's going to hopefully pull out some of the key kind of clinical parts of it, and then on to Ian. Thank you.
Thanks a lot, Andy. By way of introduction, for those that don't know me, I'm a GP based in Erewash in Long Eaton, and like a lot of people on this meeting, we'll have lots of hats in lots of different fora. So within this hat, I'm a GP provider board member, but I'm also a PCN clinical director and a GP partner as well. And I think the work the GP Provider Board has done around this, and the Appendix 1, I think it's labelled as, is a really great document. So I wouldn't like to duplicate that. Chris said something that's really resonated with me, and he earlier in this meeting he described the role of an ICB as having a statutory duty to ensure that there's good quality services that meet the needs of the population. And that really struck me as the driver behind this, because whilst it's not my statutory duty, I feel as though it's my professional obligation through the course of my career to try and do that. And I think that's shared across everyone within this forum, but probably more widely across our health and care committee. And I'm not sure we've been good enough at describing what these high quality services are that meet the needs of our population from a primary care perspective. So what do the primary care services look like? How do we want them to interact? And so rather than go through the complexities of the population segmentation and the pressures that have led to this, I thought the best way of framing this is around those patients and that population that we serve. And I'm going to do that with 3 very short patient stories to describe how that might look and how this form of primary care service model would look for those people. And the first example is of a 45-year-old lady called Sunita, who accesses her GP surgery through an online portal on their website. And that online portal sends her a link so that she can book a telephone appointment to discuss her symptoms of a water infection at a time that's convenient with her. And that appointment's with a prescribing clinical pharmacist who's working across a number of different GP practices. So not based in an individual practice, but working across a number of those practices. And at the time of booking, the clinical system recognises that she's overdue for her cervical smear, and also sends her a link for her to be able to book a cervical smear at a number of locations across her area or near where she works that's convenient to her. The key part of the delivery of this is that the information is then recorded centrally so that it can be used within future encounters with health services and with primary care across that system. So for Sunita, she has a suite of prevention and reactive services that are delivered at a level of a population over that of an individual registered list that are really effectively coordinated through a medical record, delivering this really powerful informational continuity of care. For Jason's a 50-year-old man with diabetes that requires treatment with medication and with learning difficulties. And Jason requires regular input into maintaining his health. And part of that regular input is an invitation into his local surgery for a health check. And that health check's done by someone that's known him over a long period of time. That's performed by a practice nurse who's been there for 10 years and that knows how Jason likes to be communicated with and understands his preferences of care. And at that time, Jason feels able to disclose that he's been experiencing some shortness of breath. And so the nurse is able to book a follow-up appointment with a GP who's also known Jason for several years. And we can deliver a form of relational continuity where we see significant evidence in reductions in mortality and reductions in hospital admissions. And so for Jason, we're able, using a small registered list, to build relational continuity over a long period of time to improve the outcomes for Jason and to support him in living a healthy, as healthy a life as he can with his existing conditions. The third person that we seek to serve within this evolved model of primary care is Mabel. Now Mabel's 90 years old, and she doesn't have the best mobility. She finds herself primarily at home with real difficulty in getting out. And her daughter comes round and is really concerned that she might have an infection, so phones 999. At that initial triage by the ambulance service, it's recognised that perhaps an ambulance isn't the right way to serve her primary care needs, and that information is transferred through into a primary care team. A care coordinator who's familiar with the local services and with Mabel's history is able to coordinate and work with Mabel and her daughter to work out what the best response to that presentation is, which in this instance would be an occupational therapist to support her mobility and a GP to try and treat the clinical presentation associated with the possible infection. The contact is then subsequently discussed within a larger multidisciplinary team as any needs arise from those original encounters to see what the right package of support is for Mabel within our community. And so that sense of team-based continuity that we can build up that's associated with a population of people built around a naturally occurring geography is the form of continuity, is the form of primary care services that we need to build for Mabel. So the totality of this provision is primary care. The totality of provision for Sunita, for Jason and for Mabel is within the scope of our existing primary care services. But by describing it in the way that Appendix A sets out in the paper and describing it around these patients, we collectively have the opportunity to build, to create and to deliver our services, as Chris really nicely said at the start, to ensure that we have good quality services that meet the needs of our population. And so that's what really excites me about this. I'll hand over to Ian now, because Ian would just sort of describe through, well, what does this mean, that the so what element for this? Ian?
Thanks, Duncan, and good morning, everybody. So my name is Ian Potter. I'm the Managing Director at Derby and Derbyshire GP Provider Board. So as Duncan said, I'm just going to talk really around the sort of next steps that are set out in the paper. So subject to the discussions today and the feedback that we receive, the next stage is really to work up a detailed implementation plan and a business case that goes around this piece of work. And that's really important so we can feed that into the annual planning process that the ICB has. And you've heard already around the sort of strategic alignment to a number of the key documents that we've agreed at a system level. So that's the sort of key next step. There's a couple of areas I just wanted to highlight which will support that and are referenced within the paper. The first point is around, this is a large project which will be delivered over a period of time. It's complex and it's transformational. And as Duncan's really pointed out, there's very clear alignments to that wider work that's taking place in a community setting. And we really wanted to pull that point out this morning to note that sort of link to the community transformation work and the opportunity to learn from and align resources to that piece of work and to the delivery of the model. The second point is really about looking at some of the sort of things that will make this work. We're going to need some support from the system around implementing this from a sort of program support basis, but also from aligning resources to support the delivery. And in the examples that Duncan talked about, data and digital were really key to some of those processes. And that's where those things aren't currently in the gift of GPPB. We need to work as a system to try and unlock and provide some efficiencies to help deliver this model going forward. I think just the final point I'd like to make is hopefully if we're signing off the model as a direction, it provides us with a way of something we can hold on to as a place we want to get to in the future. And as new initiatives come down from NHSE and other partners, we can use the model to say, actually, how does that fit with the model and make sure that new things that come down are in line and develop the work that we're doing. So that was all we wanted to say. Thank you, Richard. So I'll hand back to you.
No, and I appreciate that a lot. And I can see, I mean, I've seen versions of this before, so I know how much work's gone in. And I really, thank you for all the work. Just before I invite other people to comment, I just wondered, Chris, would you like to comment? Because I know you've been involved through this, and I know you're having discussions at various levels about general practice, for instance, in primary care. Is there anything you'd like to add before I invite comments and questions?
I wouldn't mind coming in properly, Chair, because I've got some thoughts to feed into the conversation, if that's all right. So you're
Yeah,
right,
that's
but
what I thought.
I'll wait my turn. I'll put my hand
What?
up and wait my turn.
Oh, are you sure? Okay, I just thought
Yeah,
some of the
absolutely.
I thought some of the things you might say might answer some of the questions. That's why I was going to try and bring you in now. But anyway, that's fine. First hand I've got up is Deji.
Thank you, Chair. And yeah, reading through this document, I think it's a brilliant strategy document. And because it would answer a lot of the questions that we have around health and care for the population. And I think if properly resourced and supported, it will produce a lot of the results that we're having. I think I'm particularly enthused with the idea of local interpretation and adaptation of the model to reflect local needs. What I, however, haven't seen, I may have missed it, is the flow back up, where if a local team does produce particularly brilliant success, how that is fed back up and shared across the system for consideration to improve care across the system.
Thanks, Deji. I'm going to take all the questions first, Ian, Andy, Duncan, and then let you come back at the end after Chris, if that's okay. I'll go down as far as Chris and then come back. So the next one was Jill.
Thank you, and thanks to everybody for the presentation. I wasn't at the May session because I'd not joined the ICB until after that, so it's been an interesting read for me because this is the first time I've kind of seen it. Obviously, primary care is a key component of our system and really crucial in terms of our efficiency arrangements. Certainly, when we're thinking about that sort of that trinity of sort of efficiency, workforce and finance, it's a key partner in terms of that delivery. And so it's crucial that we get this right. Some fantastic examples of how it's working in practice, which is really, really positive to see. I suppose I'm coming at it from the sort of chair of the System, Finance, Estates and Digital Committee. So it's wanting to make sure that where we can capitalise on all those three elements that we do so. I know it references digital and estates, particularly in the paper, but I think it's key to sort of getting that up front and central so that we can utilise what we've got or look at what we need to change. But there's obviously a longer term impact on some of that and the capital consequences of it. So I suppose it's just thinking about that in the round and making sure that we pick that up. And then finally, in terms of the sort of governance arrangements and the architecture, it looked a little complicated to me. So I was hoping that we could make sure that where we've got the governance, it supports and facilitates what we're trying to achieve rather than hinders it. So it's making sure that we can have a sort of smooth process, but ensure that everybody is safe in that governance forum. So just a general, I'm sure Helen and colleagues are working hard to support you with that, but a fantastic paper. Thank you very much.
Thanks, Jill. Sue.
Thanks. I think it sounds a really exciting proposal, and I can see real benefits for patients from these proposals. I just wondered how far this has been tested out with GPs more broadly, because it's obviously you've got multiple providers in this, and wonder how, if you've got different levels of engagement in different places, how that would be managed if we went down this route. And also whether you are learning from around some of the practicalities of how you manage sort of people being receiving services from different teams, from examples that we've already got in practice. Because I was out with the home visiting service last week, and one of the things they were talking about was some of the difficulties in managing the transfers to and from the GP referrals and making sure that that was coordinated well. So if the diagnostics, the reports go back to the GPs, and how all of that is going to be picked up as part of the development of this, but really supportive, and it sounds like a really good way forward.
Thank you. Chris Viner.
Thank you, Chair. So look, I want to first start off by saying primary care general practice is the bedrock of the NHS. Everything else builds from that environment. And I warmly welcome this approach. I can see from this approach a way through, you know, the issues that we have in terms of managing complex patients, highly complex patients, and in a world in which we've got increasing numbers of people who are in the older age brackets with more long-term conditions, multiple long-term conditions that they're facing. I could see a way through to actually strengthening our primary care offer to the community. The reason I wanted to just focus in on this is because it's all too easy for us to see this as a primary care general practice led approach, which will be delivered entirely by primary care and general practice. We have partners sat around the table today from our acute trusts, our mental health trusts, our community trusts. And actually, I believe there are implications for their future ways of working from this model. And I want that recognised up front so that we can start to have those conversations about how do we come together as a system to ensure that the bedrock of general practice continues to be supported going forward.
Thanks, Chris. I won't say anything I could add to that as well, but it's a good point made. Margaret.
Thank you. My first thought is this is absolutely excellent, and it will come as a massive relief to communities who I think are unsure about how primary care is actually working at the moment. So I think it's really, really good. I endorse Jill's point about simplicity and also the concept that Chris just said, this is the bedrock of everything, and therefore we must come together as a whole system to deliver, not just rely on the GP provider board and the colleagues. So I think my observation would be it would be such a relief, I think, to communities to know that this work was taking place. And then secondly, to make sure it's really effectively communicated so that people with a nostalgia for the old family doctor who does everything can understand that this is a really powerful way forward that will mean we all get access to the level of primary care we need. So I think putting quite a lot of thought into how that communication takes place, A, that something is happening, and B, as it progresses what's happening, and then C, where we've got to and how it works, will be really, really important. So thank you, Chair.
Yeah, I can't disagree with that at all. It's interesting. Duncan brought up the app, but there's 111 in all of this as well. I think it's going to be an important part of all of this. Chris Clayton, you're next, and then Paul Lumsden, and then I'll come back to Duncan et al. to respond, if that's okay.
Thank you, and apologies. I seem to have an unstable connection in our headquarters this morning, so if I'll probably lose you right at the sort of peak moment of what I'm about to say, but if that's right. So I've got comments and some questions, if I may. So I think the board previously has concurred with Chris Weiner about the bedrock nature of general practice in the health and care model. We previously committed to that, and we have actively supported the GP provider board and took a decision some months ago to give some commitment to it. So I think that's really important. But if I think we need to come back, Chair, and reaffirm our view, because as we plan for 24-25 and beyond, we'll need to put that at the heart, therefore, of what we do. So it's a really serious point I want to make. Before I give more comment, just to remind colleagues, I personally have no direct conflict of interest now, but I do want to just note to the board that I remain a member of the Royal College of General Practitioners and remain personally very interested in this, but have no direct conflict of interest anymore, having not been a practicing GP for a number of years. That said, I'm really grateful to our GP leaders, and I'm going to ask some questions that pushes you, I'm afraid, so please be warned, because there's a reason over the last 5-6 years we've supported the development of a Derby and Derbyshire GP voice, and I'm afraid we really need to now get the leverage out of that. On your behalf, Chair and Board, I meet probably 2 to 3 times a year is the basis with every single primary care network, the leaders, including clinical and managerial. I'm in my second wave of doing that, and I'm just going to share with the board some of the emerging themes that have come out from those important conversations. It's not possible for me to meet every single general practice. I've got 114 or so. I would if I could, because it is that important to me about this bedrock nature, but a happy balance seems to be the primary care networks. But what my colleagues are advising me is that we have some really serious structural challenges that are facing general practice, and we need to be really clear in this conversation. There is something about general practice as a thing. There is something about primary care that is broader than general practice. Both are important. It's not one or the other, both are important in my view. And I'm very clear what I'm about to say is about general practice. What colleagues talk to me about and they raise with me and it influences my thought is that we've seen a significant shift in the workload, the work type of general practice and general practitioners. We've seen a huge shift in terms of the complexity that's in a surgery, an individual, consultation list now in the last 5 to 10 years, so that actually my GP colleagues have very few, in inverted commas, simple cases, and actually strategically we've pushed that because we've created additional roles, we've supported additional roles to do that. We're promoting the R scheme where we're seeing mental health practitioners, physiotherapists, we're seeing pharmacists and so on. Take away those roles. So strategically we've increased the complexity of the GP consultation list. I think we need to note that. And so when I left general practice, my average consulting time was 17 minutes per case, even though I only had 10 minutes per case. I suspect that's changed even more. We're seeing, though, a shift of funding. Colleagues are reporting to me a shift of funding. So as we've strategically put more money into primary care networks, quite rightly, to create that working together, we're seeing a challenge to individual practice and individual practice unit financial sustainability. So that's something strategically we need to think through. And we're seeing some challenges in terms of the individual supervisory requirements for all of the additional roles. So colleagues we're creating a new general practice team here, but that needs to be supervised and developed and trained. So that's a challenge, and there's something about the infrastructure we need to think through. And then linked to that is the financial security upon which we want our general practices to build. So I'm hearing a lot around uncertainty from general practice around the contractual framework. What's the contractual model next year and beyond? So these are the things that I thought board should hear from my visits out. And as you know, board as well, primary care general practice estate is a real concern to colleagues. We have a real mixed environment of our estate, and thinking forward, we need to increase our view of general practice in that broader capital conversation that we need to have. So hopefully that's helpful. That's what I'm hearing. That's what I'm learning. That's what I'm thinking about. A few questions, if I can, to GP leaders. I really support the document. I think that is a really well described functional model of care. It gets my full backing. that's what I would certainly want to see out there. Without being too critical, I don't think you have put your colours to the mast on the structural arrangements we need to see in general practice. The things I've described are structural challenges to general practice, and I think we need to see what a structural response is. So, you know, what's the view on that? It links very much to comments from colleagues, therefore that needs strong engagement and membership conversation. But actually I think we need to push that quite urgently. What is our view on the structural model that supports the functional model? And then I think I need to press colleagues, because there's a lot of views out there around the future of the independent contractor status, the future of the partnership model. I've got a view, but I'm interested in the view of GP provision in general practice here in Derby and Derbyshire. So what is the view of our senior GP leaders on the partnership model, the independent contractor status model? And I'd like to hear it. So back to you, Chair. I hope that's helpful. Thank you.
Thank you. Paul, I'm just going to bring you in, Paul Lumsden. If you can make it fairly quick, with sort of time's moving on, and then I want to give the guys a chance to respond, if that's all right.
Certainly, thanks, Chair. I just wanted to echo my support for the functional proposal and to think about how the structure underneath that will come into play. Within the development of this, we've really got to look at the resilience of primary care and GPs, and Andy's aware that I'm focused on that. So I think some of the outcomes really need to pick up the workforce indicators and building that expertise. But I very much like the patient story approach, and very much like the building on things that are already there, the continuity of care and the skills within GPs and primary care. So very supportive, but really looking forward to the outcomes and how we can ensure resilience of the staff moving forward in their training and development. Thanks, Chair.
Thank you very much. Yeah, just to say, I fully back the thrust of all of this. I think, Chris Viner, you made a really good point about this affects other parts of the system very much, and that's often why I sort of pull together localized care as much as I actually think as just primary care and care and general practice. But Duncan, Ian, would you like to respond? If I can give you about 5 minutes or so to respond, is that possible? Or
yeah.
I'll do my best in 5 minutes. I've written down all the questions, so hopefully I've captured everything.
I knew this paper would generate a lot of discussion, so I've allowed.
Well, I had to get a second bit of paper out of the printer to write them down. I thought one bit would be enough.
You've never been so popular.
Very true. I think it was Aji at the start. There was this really nice question around, so how are we going to share best practice? And actually, I think that talks to a story about how we deliver transformation within the setting of primary care, in which we actually have lots and lots of organizations, both large and small, and using this sort of using that distributed leadership and ensuring that sort of, so there's something around the cultural tone of how we get change within this, which is not going to be a top down, this is the way to do it, because that we will immediately get resistance to that. As soon as we try and tell an organizational set that operates in that way what to do, we will get resistance, and so that's the wrong way to do it. So that description of the gap within this document about describing how we share it actually probably tells a really richer story about the importance of using the right techniques, the right approach to deliver the transformation, which I thought was really valuable. Jill picked up the sort of points around the finance estates, digital, and trying to get this front and centre, and I think that's really clear. The reason I got to this point, and we collectively got to this point in trying to articulate something, is so we at least had a horse to back, because I think if we were to ask our public, if we were to go out to our patients and say, right, what is general practice, we'd get a description of general practice that didn't reflect the realities of existing general practice. It reflected a different reality, as I would have got a different story from other providers. And so us being able to back something and to be able to articulate it becomes really important. I think it was Margaret that spoke about the importance of communication and how, and for me, this feels like it's a continuous thing. So if we agree that this is the model that is the right model, and that's what it sounds like, then actually this isn't just a one-off communication. This isn't a one-off engagement. This is an ongoing process through the life course of it, and it's an iterative thing, and it's helping describe and support people understand what primary care is, understand how they can interact with it for their best. I probably won't talk about the governance. The governance bit's actually your slide, which is exceptionally complicated. And I'll let Ian come in on that for anything he wanted to. Sue's mentioned about to what extent is this being tested, I think, with GP, or I wrote down how much is this being tested with GPs more widely. I think that's really important. So this has come out of general practice, and this has come through lots and lots of iterations. It's been through all of the primary care networks. It's probably most substantially has been to the general practice conference, which was 2 or 3 weeks ago, with really widely supported there, and has been through the LMC committee, and Chris was there as well to sort of see the discussion that sat around it with support, which is really important for me. I think the point that Chris Weiner and Chris Clayton made, and I've got one other person, I can't remember who wrote it down, I think it was Margaret as well, spoke about this being part of a system. I think it's very easy for us to think primary care is general practice, and it feels slightly lazy thinking, because every organisation, not every, but almost every organisation is already delivering primary care. They are already delivering first contact care that's comprehensive, continuous, and coordinated. If that's a mental health trust that's seeing people who are presenting with mental health problems through an IAP service, or if that's an A&E department that's receiving some of the primary care input, or if it's an EMAS receiving 999 calls or DH. So we're all doing it already. So let's organise and discuss the services together as a primary care offering within the system. So I think that point around not seeing this as a primary care thing and let's let the GPs get on with it and it doesn't concern me, this should concern everyone because this is everyone's business, and I really value that. Chris's reflections from his meetings are great. I think what Chris said there is spot on. I think that really accurately describes the experience of lots of people. I'm really grateful for that description, Chris. You describe primary care and general practice. The third thing I'm going to add in is the role of the general practitioner, and you described how that role has substantially changed, and that this model would require further change in the role of the professional as a general practitioner, and that has its own sort of set of development needs around it. The sort of the view on the partnership model. So I have been deliberately evasive in talking about structural change here, because this is a fundamental change in approach to the delivery of primary care. Historically, we have built a model based on universal access. So it doesn't matter if you're 90 and you're housebound and you're at high risk of deteriorating, or you're 20 and you've got a sore throat and it's going to get better in 5 days. We have built a primary care system that creates a universal access system. And what this articulates is the universal access system is going to exacerbate health inequalities and is not the best way to deliver high quality services that meet the needs of the population. We need to look at how we deliver services appropriate to the needs of the population. Now, and that message is really important. I don't want to understate that is a fundamental shift in how we think in terms of the access system around general practice particularly, but more broadly. Now, if we distracted that with, does the partnership model exist and what structural changes, then we wouldn't be able to get moved on that. We'd have a discussion about the partnership. So I have been deliberately evasive up to this point around this question, because without it, I don't think we would have got the progress we needed. We'd have had a discussion about a partnership model or not partnership model. In terms of the partnership model specifically, and to try and help answer that question, Chris, because I think it's really important. I have a personal view, and that view is a very diverse view across the area. What I know we have commonality on is that there is an extremely important role for general practitioners leading primary care in local communities. And the current infrastructure, the current structure that does that is the partnership model within the independent contractor. Now, that's not the only model, and there are other models that are really successful. But that functional bit, and I'm going to stick with the functional and avoid form, that functional bit is exceptionally important. Having local leaders, general practitioners who can support and supervise across a group of people who can carry risk and make very difficult decisions around people's health and care. That function is exceptionally important, and that's currently delivered within the independent partnership model. The future still has that function, whatever that future might be, and I think that's part of the next stage of this iteration. Andy and Ian, I think I've covered everyone's questions as best I can. Andy and Ian?
Yeah, you answered it. I had a similar list, but wouldn't have been as good as your response, I'm sure. There is a lot to do just on the engagement stuff. So we have engaged as widely as we can, but there's also a sequencing thing here. So there's no point in going out and trying to reach the harder to reach practices potentially if the ICB aren't kind of lined up with us and we're coming that this is a system support. So, but there is a lot more to do around that. Absolutely, there is. And Margaret talked about communication with the public, which clearly would be a significant part of the implementation plan. That we did get invited to the Health Watch Derbyshire AGM, so it has been touched in those kind of spaces. But again, yeah, that that's a fundamental part of it as well. And this is us needing the whole system support around this, because obviously we can't do that in ourselves. And yeah, the partnership structure, colours to mast bit, absolutely, we need to get to that point, and it also has some fairly clear implications for what we as GP provider boards role is in future, because we're currently kind of established to deliver this and drive this and be a collective representative voice and so on, but actually the general practice at or provider at scale is mentioned in the fuller stock take, and we need to do that, but we also need that to be led by ourselves, by general practitioners, and that's the trick we have to land.
So can I push us on now, because Chris, your last chance, but then I think we're going to have to move on if you don't mind, because we have taken a long while on this document.
Absolutely, Chair, and necessarily so. So, yeah, I'm going to have to push back. So I think we need to do a specific ask. So I fully understand the process to here, but I come back to we have structural challenges. And I think we need to ask the GP provider board as from the ICB to actively engage in those conversations with our general practitioners on some of these structural questions. Every time I meet a PCN, I then say, the next time we meet, please can you look at the following things for me, and when I come back, let's discuss them. What's happening on the second visits is questions around, can we be clear on the functional role at individual GP practice level, the functional role at PCN level, and the functional role at place alliance and place level from a general practice perspective. And I think I'd like the GP provider board to support those conversations actively, and then come back with, in 3 to 6 months' time, to this board with, if the board agrees, with a structural thought that supports those functions. And it feels quite urgent. And if board's supportive, I'd like a specific action, please, Chair. Back to you.
Yeah, well, I was going to make that point to some extent in a different way, which was we are engaged in an exercise of visioning where we want to be 5 years from now, of which, hey, this has got to be built into. I'm really pleased we've got a document here, and you've done all this work, which gives us something to, hang our hats on about how we integrate that into the wider system and more particularly the localised care picture. And I really think, Chris, I know you want them to come back to this board, but it's got to go into that sort of exercise, because I think that's where those structural questions have got to be answered, because we have to build them into there, unless you disagree with that. And that's why I think that visioning, because it had, you know, general practice, primary care is part of the system, and we've got to look at the whole system when we do that. And but I'm really, really pleased that we've actually got the exposure. And I think the work you've done, Duncan et al, is brilliant in us doing that. Last comment, and then I'm moving on. Duncan.
Yeah, I just wanted to sort of take Chris's challenge on, because I think it's a really good and useful challenge. And at the same time, probably challenge you and him back to say, in order for us to do that, we need you to commit to this. So I can't, and we collectively can't support structural change in the context of uncertainty, because it would become reductionist. So let's be ambitious about what we want to achieve for primary care in Derby and Derbyshire, and let's really back this horse. And then I'm more than happy to take on the challenge that Chris sets out.
And I think that's what I'm trying to do by saying, let's build this into our 5-year vision, because that become an integral part of where we want to get to as Derbyshire. I do like the fact, by the way, that you're coming out with one size doesn't fit all across the whole of Derbyshire. You know, there are differences here, and I think we've got to think about that in a big way, actually, in the wider context. So yeah, I totally agree with that. And I know we've got some recommendations on the paper, and I'm sure everybody's going to agree to that in no shape or form. But I think the real art form now is how we take this and build it into what we're doing going forward within the wider system. So that's what I would say. And I think you've done a great job in getting it there, if I'm being honest, Duncan et al. So thank you. Are you happy with that, Chris?
Marginally, Chair. So
marginally, go on then.
Yeah. So I think there's an inherent support for what we have seen in front of us.
Yeah.
If we do believe that general practice is a bedrock, it has structural challenges. And if we do believe the answers come back from general practice, I do think we've got to push that bit. So it's both and, if I may. I think we need to see the functional context of general practice in the broader 5-year plan and next year's plan. And I think we need to have something back, and I would probably say 3 to 6 months, about the structural thing as well. So if we could support that, I'll be fully on board, Chair. But as you know, I'll continue to influence. Thank you.
Yeah, and you continue to reflect. Yeah. Okay, no problem whatsoever. Yeah. Okay. Is everybody in agreement with that then?
Yeah, I certainly am. Thank you, Chair.
We've not gone on, that's the wrong expression. We've taken quite a long while on that because it was important. I was going to have a break at past. We've moved on to 20 minutes, and I was hoping to get past the next paper by that past as well. But shall we just take 5 minutes? Because I think everybody, we've been going now for over an hour and a half. We've got another over an hour to go. So can we just take a 5-minute break, just a comfort break for everybody, and then we'll come back straight to you, Clive and Michelle, and the integrated performance report as the two big substantial items that we need to cover as quickly, but properly in the next period, if that's okay. So 5 minutes, it's 10:38. We'll be back by 1:45, if that's possible, ready to go before 1:45. Thank you. Hi, Clive. Michelle, are you leading this one off and then Clive, or are we passing straight to Clive?
You can pass straight to Clive if you want to save some time, because I'm only just going to make a statement and then pass to Clive. So you might as well go straight.
Make a statement and then pass to Clive. Then, if that's great. I just I didn't know whether you were sponsored, but I didn't know whether you wanted to say anything. That was all.
All good, and I won't be too long on the integrated report either.
No, well, we can take it as read. It's pulling out the main points.
Yeah.
Really relating it back to stuff on the risk register as much as anything. And probably mentioning the quarterly updates that we have to give. Okay, everybody. You might want to start recording again, Dawn, if you've stopped it.
Thank you, Chair.
Right, thank you, everybody. So let's carry on. The next paper is down to you, Michelle and Clive, on the Primary Care Access Improvement Plan. So I'm going to hand straight over to, I think, first you, Michelle, and then over to Clive, if that's okay.
Thanks very much, Chair. So we've just heard the paper from colleagues around the future of primary care. This paper is much more about the here and now, and has to be. It's a national piece of work that we're all working on, and has to come to board now in November, and there will be a further update in March. But I'm going to hand to Clive just to, again, it's another big piece of work, but I'm just going to hand to Clive to try and walk us through some of the highlights of what's happening in this space. Thanks, Chair. Thanks, Clive.
Thank you. And I'll lead this item, but others have been very closely involved. So colleagues from GP Provide Board, Chris and the Medical Directorate's team and the LMC also, and may want to come in. As Michelle said, this is a national plan. It was originally called the Primary Care Access Recovery Plan, which for us in Derbyshire here at least is a misnomer in that we have more than recovered our appointments position for general practice since COVID. However, it is obviously true to say that access remains an extremely challenging issue for patients and for practices. This national plan has two main goals. The first is to try and eliminate the 8 a.m. rush that unfortunately I think many of us experience when we try to access general practice. And the second is that patients know how their requests will be managed at the point they contact their GPs. And I think particularly not told just to call back the next day and end up in a kind of spiral. There are four elements to the plan. First is around empowering patients. This is some technical elements, so the further development and rollout of the NHS app, the further development and rollout of self-directed care, and the further development of community pharmacy and other services that can appropriately see patients. The second element of the plan is around implementing modern general practice access. This includes work to improve digital telephony, to move practices to cloud-based telephony, to make their phone systems better, to simplify and improve how patients can make online requests, and to ensure that patients are navigated appropriately, and that's both through training staff and also through developing IT. The third element of the plan is around building capacity. So some of this you'll be very aware of. We have for several years now been recruiting to AR additional roles as part of the primary care networks. We've got substantial numbers of staff, and we've invested over 20 million pounds in that over the last 4-5 years. It also, in that building capacity part, includes developing, recruiting and retaining, developing programs to recruit and retain GPs particularly, and it includes a national element to strengthen the Section 106 funding, which is the funding that general practice receives when new houses are built. The final element, and this is an area that Chris Weiner leads, is around cutting bureaucracy and particularly the primary and secondary care interface. So there are several elements to this as well. There's work that needs to be done, is being done around onward referrals within acute trusts, around the ability for acute trusts and others to provide complete package of care, complete fit notes and discharge information for trusts and others to be able to call and recall patients without them having to go back through general practice, and to provide patients with clear points of contact. So again, they don't have to go through general practice. We have within our existing contracts the lever to ensure that other trusts deliver on a set of pieces of work. It's called the bureaucracy busting concordat, and one of the actions within this is to make sure that that's properly commissioned and audited. And then finally, and probably most importantly, we are required as a system to establish mechanisms for primary and secondary care to speak together. We're fortunate in our system in that we have a long-standing Alliance for Clinical Transformation, which already does this. We have the CPLG, which Avi chairs, of course, and we now have the Provider Collaborative Leadership Board. So we have mechanisms to do this. We just need to make sure that we work them properly. I won't say much more. As we've already said, all of this work is necessary but not sufficient, and it sits within a much broader long-term vision and a much broader plan, which we've talked about at length. We have, as you see in the paper, a governance programme which is so we have an access working group which is overseeing all of this. It feeds into a network delivery assurance group, and it feeds through primary care subgroup, PHSCC, and then ultimately here to the board. We're midway through this plan. Effectively, it's a one-year plan. The PCNs have submitted their plans, they're delivering them. We are in fact starting next week, going back to review and track progress. At this point, the next immediate pressing target is to deliver cloud-based telephony for the 34 practices that don't have it by the middle of next month. And there's a lot of work going on this week, and there will be a lot of work going on in future weeks to get that done. And as finally, as Michelle's already said, we'll be bringing a year-end report to a future board.
Thank you. Thank you, Clive. I've got no hands up at the moment. So I'll make just two comments, really. Just ask you, Clive. Do urgent treatment centres play a role in all of this? If you understand me, because only from my visit to Whitworth and seeing people coming in there that couldn't actually see primary care GPs. And so I would have thought they were part of the mix in this. I just wondered. And the second thing was, when I look at these, which you make a case around funding and everything else, and I understand all of that. I just wondered, is there a return on all of that, for instance, in terms of reduced load on acute or other parts of the system, if you get what I mean? Because that makes it easier for us to understand where we might invest, because in a limited resource situation, it's really important that we actually look at the positives and the negatives in all of this. And it, I see a lot of papers that request funding. It's about what's the return on that in funding from a system point of view. So those were my thoughts when I read this. From that point of view, I have no problem with the plan and everything else. I was just thinking on the wider concept. Before you answer, I'll let Chris say something, and then you can answer totally. Chris?
Yeah, thank you, Clive. And it might not be for you, Clive. It might be for Avi, for Chris. Can you just say a little bit more about the primary secondary care interface, the reducing bureaucracy work, our response to the Academy of Royal Colleges, report, because there's a definitive thing we have to do there. And I know in this system, we are wanting that to be clinically led. So can we just get some more assurance on where that is and when we'll see the outputs, please? Thank you.
Good
Back
point.
to you, Chair.
I'm going to let Chris Viner comment, and then I'll take the response. Right, Chris Viner.
Yeah, thank you. And Avi may want to comment on the same thing. I don't know. So let's just remind people, in terms of the cutting bureaucracy, what are the asks which have been that we've been asked to implement? They're around onward referrals within the acute sector. They're around complete care, which is often sort of focused in on fit notes and letters of discharge. It's about ensuring that acute trust colleagues, mental health care trust colleagues, etc., have their own call and recall systems in place, rather than asking general practice to deliver on the call and recall elements, and that our providers have a clear point of contact for primary care to engage with on the management of their patients. Look, my role in this is, first of all, to recognise that all of these requests are entirely reasonable, okay, and they are long-standing as well. And I think we need to recognise that. These are not new requests which have come into the system in the past few weeks. These are requests that have been, certainly I've seen in other systems over the previous 10 years. So they are not new requests. And there's an implication of that. Okay, these are reasonable requests and they are long-standing requests, and yet we have not managed to make that change over those years. And I think that's in great part due to the fact that we need to change the behaviours of a very large number of clinicians and services across Derby and Derbyshire in order to effectively implement this change. And for me, that means that I can't just stand up and say, right, thou shalt do this. I'm going to have to build a process around how we get that change into the system. Clearly, we've got primary care colleagues involved. We've got the GP commissioning board. We've got our LMC. What I actually need is to build that interface between primary care and secondary care colleagues. And I'm hoping that we can do that through our clinical professional leadership group, which is chaired by Avi, and he's online today, may wish to comment on that. And then we need to ensure that we've got agreement on the standards that we all hold ourselves to as a group of clinicians, as a group of clinical services, in terms of enacting that bureaucracy change. And as a last resort, we need to be able to potentially pull the levers that we have within our commissioning structures, our commissioning frameworks, in order to make it happen. So they're very simple requests. They're very reasonable requests. The amount of change, the number of people we need to see change their practice in order to make it work effectively is very significant. So we are building a process in order to do this, to achieve this, and hope, I can't give you a time frame on it. I would hope that we'd start to see significant progress in the next 3 months. But I do recognise they are reasonable requests and they are long-standing requests, and it's about time we had that change in the system.
Yeah, I might just point out to you that culture changes generally reckoned to take about 5 years, but that's 3 months is very ambitious to change all those practices. But anyway, there we go. Does anybody want to respond to that? Because I understand what you're saying there, that this has got to be, and that's why I'm trying to push us all to think about this 5-year vision about where we want. What is the Derbyshire way? Because I think some of these things, I agree, Chris, we can't be here 5 years from now and not have done anything. Stephen Posey, you might want to comment, and then I'll just let you come back, Clive or Michelle.
I think Avi's got his hand up.
Oh, I'm sorry. Yes, I must be second.
Sorry.
I'll wait for Avi.
Sorry,
I'd actually happy to wait for Stephen first if you want on that one.
No, I couldn't see your hand, Avi. It's my fault. I beg your pardon.
I'll just comment. I think the interface is only one small bit of what Clive has said. So I think there's much more to this. We just don't want to get waylaid on just the interface when we've got the entire access plan to talk about. I think just in terms of the interface, again, I don't think any of it's unreasonable. I think it's been around for a long time. I also don't think it's anybody's fault. I don't think we should be apportioning blame here on any individuals. It is, I think, an outturn of the complex ecosystem that we work in. But the reason we're saying this is not for the sake of it. It's because, and this might be very selfish on general practice's part, general practice spends a lot of time dealing with this sort of administration and can you chase this result? Can you do this referral, et cetera, and if they didn't, they might have a little bit more time to do other things. And it would be unfair to say that only comes from secondary care, because it doesn't. It comes from various organisations onto general practice. So I don't think we should point all the fingers just at big hospitals and consultants here. And I think that's one aspect, but we need to look at all of the other aspects, whether that may be from the Department of Work and Pensions, from demands for different bits of reports and other areas of bureaucracy that GPs have to deal with, which really is not a priority. I think the plan with this would be to have a discussion at CPLG to get a clinical agreement on where this is, and I'm sure that would be a sensible way forward, and I'm sure that a clinician to clinician discussion would get us somewhere. And then I think we need to look at how we implement this as a system, and how we make sure that ever-changing staff in organisations are aware that this is the case. I'm sure Stephen will be able to iterate various reasons why this occurs, and I also think general practice has a part to play in this as well. So it can't just be unilateral here. So it's a complex bit. I think we'll work through it, but I think in order to do that, we need to have an agreement that this is the correct way on all sides of, I don't want to say fence because we're in one system, but on all sides, if you see what I mean. I'll come back a little bit later, so let Stephen come in on that. There are a couple of other comments I wanted to make on the whole plan.
I haven't got much time, Avi. That's the problem at the moment.
I think the only other comment on the plan is that I agree with all of it. It's great. A lot of the devil is in the detail of this, and a lot of the devil is actually releasing general practice or primary care, with one eye on the conversation we've just had, to be able to utilise these resources as they see fit. Ours is a very clear example of where they're not allowed to do that, and hands and feet and everything are tied up with being able to utilise those monies for the best way to care for the population. And the other thing is, I think Margaret mentioned it before in the previous discussion, and it's ever so important, which is taking the public on this journey with us, because the public and the patients and the service users, the population, do need to understand that it's a little bit different, and it's not just seeing a GP, and that's actually better in terms of the care that you receive. And I don't think, perhaps none of us are as great at doing that, and that's where the system can really help to take the public on the journey with us with that. That was the only thing I wanted to say on that.
Great. Stephen Posey, and then I'm going to bring this to an end.
I'm going to be very brief, Richard. Just to say, as PCLB chair, it's something we're going to spend some time on at the collaborative, and there is that commitment. But I think there's also something about joining this up, because I'm not going to be explaining why the system is as it is. I think Avi's done that. But we do need to understand, if we can reduce demand on primary care, that will help us with the UEC flow across the system. And I think joining that up in terms of the conversation across all the providers is going to be very important. But there's a commitment, I know, from all of the providers to do better on this. Thanks.
Yeah, and by the way, I'm on record. Don't beat ourselves up for where we've been. It's all about where we are and how we move forward. So I'm totally with you on that, Avi. Don't get me wrong. I'm going to draw it to a close here, because I think as a board, we either agree, yeah, we're going to move forward and accept this, but how we actually implement it has got to come in the development session and the 5-year plan. Otherwise, we can't do that in this session, if you get what I mean. So, and I think we're in danger of that if we're not careful. So, is there anything you'd like to say, Clive?
No, thank you. That's great.
Right.
Thank you.
So thank you very much for the paper. I think you're getting general agreement on this. Everybody understands it. It's now how we build it in going forward, and don't lose the opportunity in that vision going forward. So I keep pushing us back into that 5-year vision, because that's what we've got, where we've got to balance all of these things and things that we've not talked about today. But I think you've got I do actually appreciate the fact we've had a good look at general practice and primary care today, and it's put it where it needs to be. I think, Michelle, you've made a comment in the chat about how we build this into the planning, and I think that is the $1,000,000 question going forward, because I think you've got the agreement of the board that these are important issues that have to be in there today. And so thanks for the effort. Right, I'm going to move us straight into the integrated assurance report. I'm going to have to request people to take it as read and just pick out the things that are, you think are critical. Chris, do you want to open it up? Is there anything you'd like to say generally, and then we'll move through the sessions?
Only, and it links to the Secretary's the letter from England linked to the financial settlement with government for the remainder of the year. This concept, this is what the report's about. It's the concept of balancing operations with money and people, underpinned by quality and safety. That's our approach. So symbolically, you're seeing it now, but going forward, we're going to be building on that. But over to colleagues. I think Michelle's going to kick off and take us through. Thank you.
Okay, thank you.
Thanks. Thanks, Chris and Chair. So I'm not. Look, I'm going to take the report as read. There's a whole host of data in there, but particularly from an operational point of view, I think the comments I want to make is that the data that you see here is very much, particularly from an operational performance, it's validated data. So we often don't get that data so that's August and September data, but just so that and a lot of colleagues on the call today will be aware of this, but for those watching, a lot of these metrics are looked at on an hourly basis, a daily basis and a weekly basis, and there is significant scrutiny of this performance and actually what's underlying that performance and the delivery of that. So just to give you some idea, particularly around elective and cancer, these are weekly meetings that we have as a system scrutinising that performance, but also the cause and effect and what we can do to improve that situation. And I'm really not going to say much on the UEC, the urgent emergency care. We'll come on to, I'll probably make some comments on the winter plan, Chair, if I can, around that. I suppose there's just some vulnerabilities around our performance in some of these areas as we start to see going into the winter pressures, and I think you talked about that at the beginning, Chair. So it was just to give some reassurance that there is a lot of scrutiny underneath all of this performance, and I think we take your point, Chair, around the integrated performance report and to Chris Clayton's point about how these things triangulate together and underpinned by quality and safety, and there'll be more work to do in this area. But I will happily take any questions specifically on any of those operational points, but you may just want to, I might want to just hand to Linda and then Keith and Dean in terms of anything that they want to say around their parts to then triangulate this. So maybe if I go to Linda and Dean, Linda, and then Keith, Linda and then Dean, and then Keith, because the financials are outputs of all of this.
Okay, thank you. Yeah, thank you, Michelle and Richard. Again, I'll take the report as read. So I won't go through all the numbers. I think just thank you for your comment earlier on, Richard. And I think what I would ask people to note is the fact that I think we can take more confidence in these numbers, and that is down to a huge amount of work by people services teams, both within the ICB and across the providers. So we're reporting again in two ways. So we're showing a lens against the plan, which shows us being slightly over in terms of where we expected to be, but you can see there is a slight downward trend in terms of growth, which is what we want to see. And then we also show the workforce numbers against the pay bill and the actual establishment. So you can see how those are trending. The thing I did want to just draw people's attention to, which is new in the report this month, is the section on agency usage. And this is something that we've been required by NHSE to now report formally at the board in terms of our plan to reduce our spend on agency staffing. So you'll start to see this every month. And I think the interesting thing with this is to understand what's driving that agency spend. And there are two elements that we're working really hard on. One is about the controls around the use of agency, and I know all the providers have significantly strengthened the processes that they have in place to sign off any agency expenditure, and I do expect that will start to be seen in the figures. But of course, the other element is around some of the services that are driving the use of agency. So that then links back into some of the conversations we've had about fragile services, some of the services where there are very deep-seated and long-term supply issues in the workforce pipeline, thinking about things like CAMS, about oncology. So it's a complicated picture, but it's one that we are working really hard to make progress on. So I'll stop there, Michelle, and hand on to Dean, but obviously happy to answer any questions at the end.
I'm going to take questions at the end. I'm going to take questions at the end, Sue, if that's all right.
Thanks, Chair. Thanks, Linda. It was just three areas I wanted to bring out of the quality report. Firstly, on our maternity services, both locally but also the broader view regionally and nationally. I can confidently say that by the time our board takes place in January, we will have received the full published report into UHDB. And just for some broader assurance, and I know, Stephen, you were working very hard with your team daily and weekly on the Section 29 improvements that we need to demonstrate by mid-December. But I think there'll be an opportunity, Chair, to have a full session at the January board, not just on the plan, but on the broader cultural elements that we'll be working through in partnership. I think linked to that, the primary care interface with the CQC is growing with gusto. As we know, there's a real focus over the next 3 months on the responsive domain within primary care. I know colleagues are fully aware of that, and the ICB primary care support team are fully engaged, and thanks to Clive and the team for that broader support as well. But I think we need to have an honest discussion, as always, around sustainability of improvement in that space. So I think that work will flow through certainly in the next 3 months as that activity continues. Linked to that, the theme that we had at the board earlier this morning, I think the time is now right for us to reconsider extension of SR2 in our BAF around short-term operational needs, not just having an impact on health outcomes, but also having an impact on sustained quality compliance. And I think that's a theme that the quality and performance team and Deji and I can really start to kind of add some pace into, because I think we do need to take note of the increasing pressure on compliance. So, Chair, I'm just signalling that at the board, and that is vital work that we will take forward in this next month. And then two further areas just for note, really. I have pretty much now completed all my frontline visits in my first 3 months. And what is really evident is that we have a very strong culture on the quality compliance and certainly the quality reporting, and we can always finesse that, but we are slightly less focused on quality improvement as a system. And what's really interesting, some of my frontline visits, I've been able to walk through a whole quality improvement journey. I was able to do that certainly at Chesterfield 3 weeks ago around their kind of new A&E service, actually. But I will be asking the board as we get into certainly post-Christmas period via the committees for us to more systematically consider our improvement methodology as Derby and Derbyshire. And I think we've got great skill and great energy already in that space, but I want to bring that together. And finally, I did want to add a special note for our safeguarding approach in partnership with our local authority. I remain incredibly impressed by the ICB's contribution in that space, but more importantly, the way the local authorities are responding to increased pressure on safeguarding referrals is very clear. I've met with both independent safeguarding chairs, and our child safeguarding team are working in close concert with all the multi-professional safeguarding hubs around some high-profile cases, which I'm sure I'll be able to brief into the new year. Thanks, Chair.
Thanks, Dean. Those comments around sustainability and continuous improvement, they're very linked to culture. Very linked to culture. Yeah, okay. Keith, please.
Thank you, Chair. You'll see from the report that at the end, £1 million away from our important though that we focus on where are we heading towards the financial year end, and you'll see in the report again dependent on a number of things, not least of which is industrial action. There's a potential 60 to 70 million pound overspend as things currently stand. That is more or less entirely driven by things that have changed since we planned and submitted our formal plan back in May. So I'm looking particularly at cost of industrial action, inflation in all areas, not just prescribing and consumables within hospitals, but also in continuing healthcare services. So across the whole spectrum of acute and primary care. So potentially 60, 70 million pound challenge as we run up to the year end. Obviously, that's going to be influenced by our level of productivity that we can deliver over the winter period, as well as the cost of securing safe, urgent and emergency care over the winter period. So all those plans, both operationally, workforce-wise and financially, are being coordinated as we speak. It would be remiss of me not to reference what's been in the national press in the last week or so about additional resource being put into the NHS for our system against that potential 60, 70 million pound problem. Our share of that national funding is down to 12.2 million pound. So we've got a lot of work to do to square off the financials alongside the workforce and the operational challenges that my colleagues have already referenced over the winter period. And it'd also be remiss of me not to reference the fact that the financial pressures are now being felt in all areas of the system, not just the acute care. We've got overspends emerging in primary care, in mental health and in community services, as well as already mentioned CHC. And out of area placements and some of the contracts we have with our independent sector partners, who are we dependent upon to maintain the lowest waiting times that we can possibly can. So, and the financial pressures are now quite widespread. So a lot of work being done this week and next week across all partners of the system to triangulate performance expectations, workforce and money, all in the auspices of maintaining safe care over the winter period. So we'll probably bring more of that back when we meet in next 4 or 5 weeks. So I'll leave it there. Thank you, Chair. But hopefully the sound bites are poured out to connect with what colleagues have already shared in their other areas. Thank you.
Yeah, thank you. And I am aware that of all of these, that this is the end of the first half year. That's where we were at the end of month 6, and yeah, there's 6 more months to go, but some big demands on us. Chris, did you want to say anything about that letter anymore? Because it is a particular challenge for us going forward, isn't it?
Only in the sense, Chair, that obviously we received it this time last week to give assurance to the board that the right expert colleagues are working across the system on those individual components, and we'll be working to bring a view and a recommended view to a further session of the board.
And we've put a special board in for that. That's so that everybody gets a chance to see it. But I recognise the work that must be going on at exec level to meet the requests in that letter. So I accept that. Right, would anybody like to raise any issues or questions around the integrated performance report? I have to say it has moved on a long way. Sue, yes, I was hoping you'd come back.
It was about the agency. I think it was really helpful to get that extra information around agency. I'm really pleased that we're investigating the admin and estates bit, because that looked a bit odd through the EMAS stuff, and that's great. I suppose the other bit that we wasn't touched on was the off framework usage and the costs associated with that, and what's being done around that and trying to reduce, if not eliminate, that. conscious that at the trust that I'm involved with, we've actually stopped off framework usage. There was a lot of worry that it would cause clinical problems, but we've been able to work around it. Now, I appreciate that might be different for different types of trusts, but just wondered how far we were pushing that to see whether actually it might not generate the pressures that we think it will.
Keith, you got your hand up, and then
are you going to answer
Linda,
that,
do you want to
Keith,
come back on that?
Well, just to say that you're right, Sue. You know, the plan is to eradicate. That is the intention, is to eradicate off framework usage, and that goes back to the point I was making about the controls that providers are putting in to manage that. It's a really difficult one, isn't it? And you know, I think a lot of the providers will say that that is in our process, but when push comes to shove and you're faced with a really difficult decision in the middle of the night, what do you do? So I think the controls that people are putting in, I think we should expect to see that change. Whether we'll be able to totally eradicate it, I'm not sure, but I can't disagree with your point. I don't know if Keith thinks any different.
Got your hand up, Keith.
Yeah, I wanted to mention at different points, so there's nothing I can really add to what Linda said. I think it's the reality of keeping patients safe, isn't it, really, and doing the right thing in the moment. And sometimes we have to take the appropriate action. I just wanted to mention up at the end, really, about context. I've described the Derbyshire systems position. I just wanted to finish by saying that, and what I'm saying now isn't at all complacency, but I think it is important to recognise that financially the Derbyshire system is one of the best performing financially in the Midlands, and particularly given our complexity, that's even more more important to observe. So I'm not at all saying that we're in a good place, but what I'm trying to say is the challenges that we're dealing with certainly, and that are translating through to the financial bottom line, are being handled, it would appear, in a more controlled way than other parts of the Midlands. And I'm not saying that's a point score. I'm just trying to make it relevant that we're all dealing with big issues, and there is a collegiate response from the Derbyshire system that is manifesting itself in the financials, even though they're not where we want to be. We are doing something which is containing and managing these things, it would appear, you know, in a good manner relative to other parts of the NHS, which are all facing with the same challenges. So I don't want that to sound like bravado or complacency or arrogance. It's not why I'm raising it, but I just wanted to make sure that it was appreciated that all parts of the NHS are dealing with the same kind of issues, and we're in a good place to have the right conversations with hopefully regional and national teams, given our relative track record. So I'll leave it there. Thank you, Chair. But again, don't take complacency or acceptance of the numbers I've reported in what I've just said. Well, thank you.
Thank you. From my point of view, I think I'd like to say it would be really nice, and I'm sure Stephen, you'll agree with me on this, to have a bit of period of stability without strikes and things to get hold of some of this stuff, because we have not had an easy time from that point of view up to now, and it's very difficult to get control of some of them, of these issues, with all of that going on. So we're being asked to plan forward, assuming no more strikes, but you can all decide whether you think there will be or not going forward. So I think that's the really difficult thing in all of this, if I'm being honest. But it would be nice to get a period of stability, wouldn't it, Stephen? And I haven't mentioned the impending election coming up. Okay, so has anybody else got any? From my point of view, can I say thanks? There's a lot of information in that integrated performance report. I still think we'll need to do some work to try and, you know, streamline it a little bit, make sure we're actually bringing out the things that we really need to look at. That balance between the short term and the long term, I think probably I'd like to see some stuff in there around how our inclusion agenda, for instance, and things like that. How are we measuring that? How are we getting there over the 5 years? Our prevention, the healthy life expectancy aspect to it. those sorts of things. I think how we measure that going forward as a board and that we're actually implementing it against our vision in the 5-year plan, I think that's going to be the next step. But I do think we're now starting to cover the whole system. I think, Keith, good work on cash. If we hadn't have done some work earlier on in this, I think that would have been a really difficult position for us. Now I think that's great. And I suspect, well, I know that certain other systems have got real cash problems at this moment in time. So well done. Thank you. Okay, I'm going to move on now to the committees. There's a lot of information there. I'm just going to go down them one at a time. Sue, audit and governance. Anything you want to bring out?
You're not doing anything on the operational plan then?
Oh, sorry. I beg your pardon. I beg your pardon. I'm not scrolling down fast enough. I beg your pardon. Yeah, Michelle, please.
Thanks, Chair. So most of the board members will have seen previously the operational plan. This is the refresh for the final 6 months of the year with a focus on winter. I'm going to take it as read. There's just a few things that I wanted to pick out in light of well, October, I mean, this is week 7 in the role here in Derbyshire for me, but October saw some quite volatile performance really around the urgent and emergency care, and so really what we need to enact for winter. I think we've got a good plan. There's the gap around the acute respiratory hubs, and we're going to manage that, and we have a plan now for that. Virtual wards and single point of access board, I'm just highlighting that to you. That will be something that's clearly important. We spoke about virtual wards previously, but they are going to really come into the forefront in terms of how those 3 things really, acute respiratory hubs, virtual wards and single point of access, are going to really help us across the system over winter. There's an awful lot of other things within that winter plan. I think my final comment would be it's a plan, it's live and dynamic. So what's in this document is very live and dynamic, and now it's about delivery. So enacting this plan and delivering, and then monitoring against that, and monitoring our risks against that. And I will lead that from a system point of view, but happy to take any questions given time, Chair.
Yeah, and we did see a version of this at the last confidential board, so it's an update of that. Has anybody got any questions? We did ask a lot of questions at the confidential board, so and I think you've answered quite a few of them in here, actually, if I'm being honest. Okay, thank you very much, and thanks, Michelle. I know it's hard at the moment. Okay, sorry, delay.
Right.
Back to you, Sue.
No problem. I'm going to take it as read. It's the different thing this time is that we've got the annual report attached, which hopefully people found useful to read. The point around the matter of concern we flagged was that we know that the board is very well cited on the financial position, but what we benefited from as part of the deep dive was that looking at the underlying issues and constraints that impact on how well we're able to mitigate some of the pressures that we're facing, which I've briefly summarised on the assurance slide. That actually I think it's just helpful for people to keep at the back of their mind when they're looking at the pressures that we're facing, because we have some pressures that make it more difficult for us to address than it does some other systems, and we found that exploration of that very helpful for us as a committee. The only other issue is the work we've got ongoing in regard to procurement, which is work that we're going to come back to and follow up on. Nothing else I particularly want to raise.
Yeah, I think that procurement work is really, in the light of some of the things that we've gone through over the last few months, is a really useful piece of work, and I think really important in the trying to get ahead of procurement, I think, was the big thing that I picked up in it all. So anybody, any questions? Okay, Jill's SFEC.
Thank you. So I won't go over the stuff that Keith covered in the financial report. You've had a view of that already. We picked up some issues around workforce and had a really helpful presentation on workforce, and which gave us assurance in terms of the more detailed aspects of that, but it's obviously how that's then implemented into the long term. So we think we've got a better picture of it, but there's obviously still work to do. In terms of the efficiencies, it's about the transformation and making sure that we end up with the these transformations being embedded. And although we've got a positive in terms of the plan and the savings being 2 million over at the moment, that's because of the non-recurrent aspect of that rather than the recurrent. So we're under on the recurrent, we're over on the non-recurrent, and what we need to do is turn that on its head and make sure that we've got that delivery which is then on a recurrent basis, and only then are we going to be in a better financial position. So good work being done, but lots more to do. There's obviously, Keith mentioned about the national funding letter and the conversation that came after our committee, so we'll obviously pick some of that up as we move forward. And then we had a bit of an interesting conversation about the wider role of not only Finance, Estates and Digital Committee, but how that plays in with other committees, and therefore the value that we can add to the board discussions. And Chris Clayton said that he'd have a conversation with Helen Dilliston about how we might pick some of that up. I think perhaps as part of the refresh of the terms of reference and thinking about the clarity of the roles for each of the committees and that sort of bigger picture stuff, so that we're adding value from a committee perspective rather than that significant overlap which can occur. So I'm happy to take questions, but I'll leave it at that.
Somebody got any questions? I think what I picked up in today's meeting, Jill, Keith, etc., Jim, as I was listening to some of the things around primary care, the estate stuff started coming out quite strongly in there, and the fitness of our estate going forward. That's going to be a big issue for us going forward. And I can't help all the time, Jim. So much of this relies on having a shared care record, doesn't it? As a bedrock to a lot of the stuff that we're talking about in terms of operating as a system, and making the update of that shared care record easy, if you get what I mean, making it easy to use. Sorry, Jim, you've just put your hand up.
I definitely agree. Our shared care record is well established and rolled out. There's some work we're doing to enhance it now. Clearly, the national direction on funding and the letters, there is a lot of brakes being put on digital funding across the country, and we just need to be mindful of that. Thanks.
It's just that shared care record covers the whole system, and it's primary care right through to, and it's becoming so critical, isn't it?
It is, and there's a deep dive going to the committee in December on that. Sorry.
Yeah, thank you. Sue, I think you're going to cover Julian on the Public Partnership Committee. Is that correct?
I am. I'm going to take the.
Sorry, Jill, I didn't see it.
It's okay. Sorry, Sue. Just on the estates conversation, obviously there's an estate strategy being developed. Primary care are a key part of that. So we are looking at that, as with the digital conversation and the impact of estates on digital and vice versa. So we are trying to join the dots up, but yeah, just some assurance there. Thank you.
Great. Thank you. I thought you would be. I can hear it in the conversations today. That's what I was. Right, Sue, sorry, back to you again. We keep starting and stopping you this morning.
No, it's absolutely not a problem. There's nothing particular I want to escalate or from the committees. You've got the report and the annual report attached, so only if there's any questions.
No. Again, the same comment though. This morning, the communication with the public came out big and strong in the primary care again, didn't it?
Yeah.
Okay, thank you. Daisy, I think you're going to cover the public health on behalf of Julian. Is that correct?
Yes, I am, Chair. Yes, I am. And there are no major concerns to report to the board. So I'm happy to take questions on the report and on the annual report as well.
Any questions? No. No problem. Thank you. And I think we stay with you on the quality, Daisy.
Yes, thanks again, Chair. There are ongoing concerns around the quality and performance, and they are as outlined in the report. We've talked a lot about primary care at this meeting, which kind of speaks to some of the concerns. And one of the things the committee has done is invite primary care representation with their new terms of reference, and Andy is currently in that role and has been to a meeting so far, and that will continue to evolve, seeing as the appropriate input comes in. Regarding maternity, the committee will be receiving a deep dive around maternity from LMNS at this month's meeting, and so I'm hoping to be able to provide some further information to the board at the next board meeting. And apart from that, I'm happy to take any questions.
No, I'm glad you're doing the deep dive on maternity. Anybody else? No. Okay, so Margaret, I'm going to pass over to you for the People and Culture Committee and the Freedom to Speak Up paper, if that's okay, because I know I asked you to bring that this month.
Yeah, that's fine. So the People and Culture, we are just tabling the annual report. Happy to take any questions. The only thing I'll mention from People and Culture is, as Linda said earlier, we're working on the key issues around workforce. We've got a development session next week to look at how the committee is doing and are we really meeting all the obligations that we have, followed by a People and Culture meeting the next week. So we're a little bit out of sync with the board meeting, but we'll have something to report at the next one. On freedom to speak up, the only thing I wanted to pull out, because they could take the report as read, is that following the Lucy Letby letter, we talked about how, as a system, we would ensure freedom to speak up systems and processes were working everywhere so that people really did have that freedom. We wanted a light touch. We didn't want to put an unnecessary bureaucratic level in the process. But I've agreed as Sid to take up the role of making sure that all our systems and processes are in place and working effectively. And we'll do that by having that as an agenda item on People and Culture on December the 6th, I think it is. That was all I wanted to say, but happy to take any questions.
Yeah, because we have to do the freedom to speak up for primary care, etc., don't we now? So there has been changes. So, and I think you're telling me you're happy with the stuff we've got in place to cover all of that. Is that right?
No, I'm not telling you I'm happy. I'm saying I've agreed to take on the role of making sure we are. And we've got it as an agenda item on People and Culture on December the 6th.
Okay, fine. Thank you. So you'll be able to come back and reassure us on that the next time. Okay,
exactly.
That's great. Then.
Will do.
Thank you very much. Yeah, because I think that's important. We don't want to be stepping into what the providers have got to do. It's just we've got a duty of care to certain parts of the system, I think. Okay. Anybody got any questions there? No, thank you. We've got a number of papers for information. There is a lot of information in them, actually. I think, Ellie, the paper you've brought around the Derbyshire health and public health annual report there's a load of information in there which actually drives some of the things we're talking about today. And I know we've discussed it at health and wellbeing boards, etc., etc. So I think it's worth people having a skim of that, actually, just to make sure that you understand, the direction. I don't think there's anything you want to add, Ellie, on that one. Are you still there?
Yes, I'm here. Yeah. So just it's obviously the annual report, Director of Public Health annual report's been through various boards around the system already. You can see Chris's point in the chats about taking it to specific groups. I think we're going to the Mental Health Trust later in the month, and it'll be picked up there. So it sets out some of the stats around mental health across the county, and then also builds on the Let's Chat campaign that we've had across the county, which hopefully most people will be aware of, and there's sets out at the end actions for both individuals and organisations in terms of promoting good mental health across Derbyshire.
And we ought to be reading that in the context of the financial pressures you guys are coming under at the moment, I think. I don't think we should ignore that.
No.
Because that has a direct impact on us all when we think about the greater system, the wider system. Okay, there's the minutes of the Derby and Derbyshire Health and Wellbeing Boards for information, and we've got minutes of the Audit, Governance, Partnership and Quality and Performance Committees. Okay, so I'm trying to scroll down as fast as I possibly can. I beg your pardon, everybody. Right, there's a forward planner in there when I get to it. Has everybody seen the forward planner? Our next meeting is, I think, the 14th of December, which is a wider system workshop following up on the one on the 19th of October. Yes, yeah, that's right. So I hope we'll see you there. I think what I would say is that it's come out a lot today about how we build some of these things into what we do going forward. I mean, I thought the papers on the general practice, I'm really pleased we had those papers. They took a lot of time, and we'll have papers on other things going forward because we've got to cover the whole system. But how we build those into our plan going forward is really, really critical because we have a lot of resources to balance. What I will say to you is I've sat on a couple of meetings with NHSE, etc., over the last couple of days. One with Richard Meddings, I think it was on Tuesday or Monday. I don't think it's going to get easier financially. I mean, the fundamental issue is the pressure seems to be on getting more out of what we've got. The focus is on efficiency, productivity, using the resources correctly. And I don't think that will go away. We sit here as a country where our national debt is 98% of our GDP. It is not going to get a lot easier, I'm afraid. But the one thing I do see in some of the discussions now is the opportunities. I mean, there's discussions now about bureaucracy. There's discussions about how we can improve flow. There's discussions about where we don't double up on things. And I also see more and more discussions between us and our partners about, and I try to cover that very much on the early start, there are opportunities there. So I'm far, far from despondent about this. I think there are massive opportunities. That continuous improvement culture is something that we can really look to build, and it will drive massive dividends. So thank you very much, everybody. Has anybody got any other business they'd like to raise? So after all of that, I'm going to let you go 4 minutes early. I've given you 4 minutes of your lives back. So I hope you appreciate that. And I'll see the rest of you in, I think we're due at 12 o'clock. Is that correct?
Thanks, Chair. Thank you.
Thank you very much, everybody.
Yeah,
Bye-bye.
thank you.
Thank you.